Hola, muchas gracias por continuar con nosotros. Tenemos el gusto de presentarles al doctor Sebastiano Mercadante. El doctor Mercadante nos va a hablar sobre su experiencia en las unidades de cuidados paliativos. El doctor Sebastiano Mercadante tiene un doctorado en medicina y cirugía de la Universidad de Palermo, especialización en anestesiología y ciencias y nutrición de la Universidad de Palermo. Es titular de anestesiología, cuidados intensivos y terapia del dolor y director de la unidad de anestesia y cuidados intensivos. Es director del Centro Regional Principal para Alivio del Dolor y la Unidad de Cuidados Paliativos de apoyo de la Maddalena, Palermo, Italia. Tiene más de 700 ponencias en congresos nacionales e internacionales. Es profesor adjunto de Medicina Paliativa del MD Anderson de la Universidad de Houston, Texas. Miembro de la Comisión Ministerial Nacional para el Dolor y Cuidados Paliativos. Primer experto mundial en dolor oncológico y dolor irruptivo. Presidente del subgrupo de cuidados paliativos desde junio del 2024. Para nosotros es un honor tener con nosotros al doctor Mercadante. Por favor, la bienvenida. Muchas gracias. You want to use this or that?
Muchas gracias. Muchas gracias for la invitación. Unfortunately, despite the several time I came to South America and in Spanish, I didn't learn too much to make a presentation. I will talk about palliative care, the models of palliative care we introduced in Palermo many years ago. We have different models of palliative care. The home care, most of the time patients spend their life at home. The hospice care, this is an inpatient unit. The palliative care service consultation in a hospital, and what is more important for me is the acute palliative care unit.
Excuse me, doctor. Las personas que necesitan interpretación, aquí está la mesa con los equipos.
These are the conventional aspects of continuing care: diagnosis, treatment, relapse, and then palliative care, just only at the end, just 1 month, 2 months, 3 months before that. This is wrong, in my opinion, because palliative care should be intended in a different way. This is the definition of palliative care, very old, but in this definition, you can see palliative care is applicable early in the course of disease in conjunction with other therapies that are intended to prolong life. That means that palliative care should start with diagnosis of cancer in these cases. This is the modern continuum cancer care: diagnosis, but curative efforts with life-prolonging therapy, with supportive and palliative care. There are multiple settings of palliative care, not only the hospice or the home care, normally dedicated to the last weeks of life, but oriented in the hospital, where the palliative care patients are, not at the end of life. So we need a full integration between the oncologist and supportive care physician with two objectives: the tumor-directed approach, treating the disease, of course, and the host-directed approach, focusing on patient with disease. That is a different way. In more than 25 years ago, we created this unit that still remain unique all over the world, because there are no many other units such as the unit we produced at that time. The aims, they were diminishing the physical and psychological distress of patients, redirecting the palliative care pathway, and when the curative approach are no longer possible, to promote the transition versus the so-called palliative care. In contrast to other centers, hospice, for example, the unit was developed according to a specific format that distinguishes from the other long-term palliative care institution. This is the model and also the economic evaluation of our unit that has the reimbursement similar to any treatment in hospital, acute hospital. Patients are admitted for different reasons. Of course, pain, one of the most important, and also other distressing symptoms. But again, the derangement of the general condition, and of course, to have the possibility to exchange opinion with our oncologist regarding the possible treatment or the withdrawing of the treatment. We performed with Eduardo Bruera a review about the acute palliative care all over the world. Only few studies, and most of them represented a country particular situation in which, for example, acute palliative care is used in case of no hospice, for example. So the staying and the mortality is completely different. In my unit, the mortality is under 10%. That means that we see patients who are in the early stage of disease, where we will continue the treatment, for example, and so on. These are the results of our unit we published many, many years ago, in which we showed how these patients are treated, how these patients are discharged home for curative intent, for palliative care intent, and so on, to choose the right setting where continuing the care. As you can see, a good percentage of patients are declared off therapy. So this is the good point, the good time to decide together with our consultant oncologist to stop the treatment. In other cases, you know that oncology will continue with the third, fourth, fifth line without no sense. Also, against any recommendations. And you can see the setting of discharge is the home palliative care, so we can direct the patient to the palliative care. But what was surprising, most of patients, 14% of patients admitted in our unit never had a treatment before. That means that the patients were admitted for pain control, symptom control, when the diagnosis was not ready, or means also that we admitted patients with very, very advanced stage of disease, no longer receiving palliative active treatment. So is palliative care possible to use before any treatment? This is the sort of preemptive palliative care that has never been discussed previously. We, in Italy, we have more 300 hospices, and we have also the school of specialization. But however, there's only lateral referral for these patients, because in Italy, palliative care is performed just in the last 2 months of life, either at home or in hospice. So we have to switch the paradigm about the palliative care. Palliative care should be started once the patient is diagnosed with cancer, because a lot of problems emerge in these phases of disease, not at the end of life. That means years and years of care. This is the profound difference between the hospice care and the acute palliative care. It's completely different settings, also in terms of advanced facilities that we have in hospital, including research, in comparison with the hospice, in which patients are admitted only if no longer curative treatment are available, similarly to home care, of course. What about this? We created 5 years ago also an hospice on the same wing of our hospital. So we have the acute and hospice. This is fundamental because the patient can be transferred in the hospice care without having this usual waiting list in other hospice. Waiting list, that means 15 or 20 days. But in this case, we can move the patient in our same hospital and the patient are cared by the same team, of course. This is very, very important, the continuity of care. It's evident that what is possible to do in the acute hospital is completely different from what we can do in hospice. So the settings are completely different. And this is what we are doing also in exporting this model. In US exist some other units, but generally are really, really limited. So it's very important to add an hospice to the acute, otherwise the acute can get a sort of hospice without having this possibility to discharge the patient with a low level of care. Again, these are the differences in admission criteria for the acute palliative care and for hospice. Is a huge difference between the two settings. But what I think about the future, if I think for the next 10 years, just counting also my possible mortality, palliative care consultation everywhere, in any setting, in acute hospital, expanding expertise in other settings. For example, in intensive care. I am an anesthesiologist, and I worked until 1 year ago also in intensive care. But I know how many problems need to be afforded in intensive care. So intensive care and palliative care are not an oxymoron, but again can work together to select a patient when it's necessary to withdraw some treatment. Again, the culture about palliative care among anesthesiologists is really, really poor. We tried to publish also in an anesthesiological journal to underline this aspect, who should be the expert in palliative care, in intensive care, if anesthesiologists need some expertise in palliative care and so on. So the places where palliative care will be mandatory in some years, I think is rehabilitation first. Early palliative care with integration with oncologists, anorexia and cachexia clinic, the outpatient for nutrition problem, the acute supportive care unit, the outpatient referral, the survivors clinic. We now see many, many patients living 10 years, and again, they need some supportive care. Hospice, home care, consultation, also to improve the pressure, the culture of palliative care among our colleagues. Consultation for failed surgery, pre-ICU, if you have to admit a patient to ICU or not, for example, and of course, a big work in the ICU. So thank you very much for this invitation. And again, I invite you for our annual international congress in Palermo. We had also some people from South America. Thank you very much.